Welcome again, ladies and gentlemen, in the clinical sessions. I hope all of you are okay and you can receive the online sessions, and I hope you get benefit of it, inshallah. Our presentation today will be about the thyroid disorders. The slides are owed to my colleague Dr. Ibrahim Dawood. I am the presenting tutor, Dr. Mokhtar Farid, Professor of General and Endocrine Surgery. I'd like to know the literal meaning of thyroid gland that comes from the Greek word thyros, that means a shield, and eidos form that it looks like a shield because the two loops together with the isthmus of the thyroid gland, they can present as a shield. So it is the word thyrox that's coming from a Greek word, while a goiter is derived from the word gutter, that means your throat. Your throat in Latin is a gutter, so an enlargement of the thyroid, we can call it goiter as well. In order to understand the items that will be discussed, we have to take a very small idea about the embryology of the thyroid gland, where it comes from the pharyngeal epithelium at the level of foramen cecum, that is the base of the lung. From that structure will be derived the pyramidal loop, the isthmus, and most of both the two loops of the thyroid gland. While the lateral thyroid develops from the ultimobranchial body, the C cell, that gives the parafollicular cells that are considered to secrete calcitonin, which is a calcium lowering hormone. An important item in the embryonic development of the thyroid gland is that there are migrating cells from the neural crest region that will infiltrate the ultimobranchial body to give the C cells of the thyroid. So the C cells are derivative of the neuroectodermal crest. This diagram illustrates the site of origin of the thyroid gland at the level of foramen cecum. Then the structure will be dragged down along the thyroglossal duct to settle down in the normal anatomical position, where the isthmus extends from the tracheal ring number 2 to the tracheal ring number 4, and the upper part of the thyroid loop is opposite to the oblique line of the lateral surface of the laryngeal cartilage. The thyroid gland main bulk is placed anteriorly in the lower neck, extending from the fifth cervical to the first thoracic vertebra. Notice the presence of an extra loop, which is a pyramidal loop that ascends from the isthmus of the gland towards the hyoid bone, and it's attached to the hyoid bone by a fibromuscular band. Here is an illustrated diagram of the blood supply of the thyroid gland, where you see in the upper part of the figure the superior thyroid artery, which is a branch of the external carotid. Lower down near the lower pole, there is the inferior thyroid artery that's derived from the thyrocervical trunk from the subclavian. In addition, different arteries arising from the arch of the aorta supply the gland at its different sites, and these are called the thyroid-arteria, while the veins all drain into the internal jugular vein. So we have the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. Sometimes you find an additional vein, which is the fourth vein of Kochar, a fourth vein that's found between the middle thyroid vein and the inferior thyroid veins. Never mind about the other details of the anatomy. This is not our domain, but our domain is the clinical interpretation of thyroid swelling. Fixation of thyroid to its normal anatomical position includes the following structure: the anterior suspensory ligament, and the posterior aspect is attached to the side of the cricoid cartilage at the level of first and second tracheal rings by the posterior suspensory ligament, or we call it Barry's ligament. Notice that Barry's ligament is important in working near it because it contains the recurrent laryngeal nerve. So be aware of dissection at the level of Barry's ligament. And this firm attachment is responsible for movement of the thyroid gland and related structures during swallowing, being a fixed structure found inside the cervical fascia. Also, never mind about the other anatomical details. It is the anatomical revision of the arterial blood supply. The superior, as we have said, from the external carotid, the inferior thyrocervical trunk, thyroid-arteria from the arch of the aorta or from the innominate artery. The venous drainage, superior thyroid vein, middle thyroid vein, inferior thyroid vein, and the fourth vein of Koch going also to the internal jugular vein. Diagrammatic illustration of the arterial blood supply and venous drainage of the thyroid gland. When you do your thyroid incision and dissect the skin flaps and you go down incising the platysma, you find the infrahyoid muscles that are attached at the median raphe On both sides of the midline, you find two anterior jugular veins. Whenever you go in between the two anterior jugular veins, you are going to split the infrahyoid muscles and go down to the thyroid gland. So the point of clinical importance, how to approach the midline in a thyroid operation. This is via one of three methods. The first method is midway between the two anterior jugular vein. Second is the midpoint of the suprasternal notch. The third method is the symphysis mentae, go downward in the line of upper point is the symphysis mentae, you find the midline in order to separate the infrahyoid muscles, or we call it the sternal muscles. Of clinical importance also is the lymphatic drainage of the thyroid, where we can divide the thyroid into a central part and a lateral or peripheral part. The central part gives above to the prelaryngeal lymph node, and the lower part of the central aspect gives to the pretracheal lymph node, and they drain finally into the mediastinal lymph node. While the peripheral part, the loops, are draining into the upper deep cervical and lower deep cervical lymph nodes that are found in association with the carotid artery and the internal jugular vein. Of anatomical importance also is the recurrent laryngeal nerve, right recurrent laryngeal nerve and left recurrent laryngeal nerve. They are derived from the vagus nerve in the mediastinum, and then arch up, precare up, and go in the groove between the trachea and the esophagus, and end by a hook stick form that's entering the thyroid membrane. Never mind about the physiology, it's not our domain today. This is an illustration of a thyroid gland. I think it's removed by total thyroidectomy. Let's go to the clinical part of the thyroid gland swelling interpretation. And I think the clinical interpretation starts with the history taking, a thorough history taking of the thyroid gland, where we go first to the personal history. We state that the male or female patient name, occupation, having a family of five or three or anyhow. The family, the eldest is how many years old and the youngest is how many years old, with or without special habits. Personal history in the thyroid case is not just a routine item, but you can get benefit from the personal history. You can take the following examples. Physiological goiter occurs in girls at the age of puberty and in females in pregnancy or lactation. Autoimmune thyroiditis or Hashimoto thyroiditis is occurring more frequently in female. About residence of the patient, we find that endemic goiter occurs in oases and areas away from the sea due to iodine deficiency. Then we come to the patient complaint. The patient is complaining of swelling in the neck. But sometimes the patient is coming, presenting with pain in cases of thyroiditis, presenting with evidence of thyrotoxicosis, whether in Graves' disease or secondary toxic goiter, evidence of metastasis in malignant thyroid enlargement, like enlargement of the cervical lymph node. Then we go to the present history. The condition started since how many months, days, or years? By sudden onset or gradual onset or insidious onset of a swelling in frontal area of the neck about 2 centimeters in diameter, and it has either a stationary course, progressive course, or regressive course. There is rapid increase in size or slow increase. So rapid increase is found in hemorrhage in a cyst, inflammation, and anaplastic carcinoma. So whenever you are confronted with a swelling which is in the thyroid and is having a very rapid progressive increase in size, number one in your differential diagnosis will be hemorrhage in a cyst more than inflammatory lesion and more than anaplastic carcinoma. We go back to the present history. Condition is not associated with history of trauma, not associated with psychic trauma that may precipitate thyrotoxicosis, is not associated with fever, headache, malaise, hotness, redness, or tenderness. Then you have to interrogate about bones, lungs, brain, liver for evidence of metastasis. Also, ask about symptoms and signs of thyrotoxicosis. Most important of which is history of loss of weight despite good appetite, nervousness, tremors, insomnia, change in the appearance of the eye, cardiac symptoms, dyspnea, abnormal beats, change in appearance of nails, clubbing, or what we call thyroid acropathy, history of swelling in the lower limb, and red patches, that's pretibial myxedema. Continuous with the present history, you should ask about history of intake of drugs and the importance of drugs, maybe drugs that may be received as preparing a thyrotoxic patient for operation. That's carbimazole, propranolol, logalziodine. Drugs without thyroid evidence, disease, like PAS, para-aminosalicylic and thyroid drug, carbimazole iodides in large quantities, because carbimazole is a goitergene. That's to say, the long use of carbimazole leads to increase in the size and vascularity of the gland. Then I ask the patient about compression evidence, dyspnea, that may be caused by compression of the trachea, dysphagia due to compression of the esophagus. It's okay. Go you to your past history, childhood irradiation, that may be a predisposing cause for papillary thyroid carcinoma, that may be abroad due to atomic accidents like Chernobyl or in Japan. But here in Egypt, maybe due to the overdose irradiation, whether for the treatment of lymphomas in the children, some skin diseases, that dermatologists were adopting the idea of irradiation of these lesions, previous operations on thyroid gland, operations for malignancy away from the thyroid, because the thyroid swelling may present a metastatic nodule in the thyroid or extension from other cervical carcinoma, diabetes mellitus, hypertension. Here is a question why to interrogate about hypertension. This can be considered as a routine in patient that may have surgical interference. Also, it may be associated with medullary thyroid carcinoma if it is associated with pheochromocytoma, and this may be found in multiple endocrine neoplasia syndrome. Lastly, past history of other autoimmune diseases that may be an association with Graves' disease, most important of which is vitiligo, which is a skin disease. Lastly, we take the family history, if there is family history of similar conditions. Here comes also an important question. Why to interrogate about family history in thyroid disease? Number one, there is a familial type of medullary thyroid carcinoma, whether per se or in association with other members of the multiple endocrine neoplasia syndrome. Also, the condition which is called dyshormonogenetic goiter, that's a familial disease associated with hypothyroidism caused by genetic deficiency of enzyme, if the condition is associated with congenital deafness. So in such a case, it's called Bendred's syndrome. It's called Bendred's syndrome. Okay? So the first step again in the clinical interpretation of a thyroid swelling is the history taking, personal history, present history, past history, and family history. This is the dyshormonogenesis or Bendred's syndrome if it is associated with congenital deafness. As you know, all the hormonal synthesis procedures are enzyme dependent. So if there is deficiency of peroxidase or dehalogenase enzyme, iodine will be trapped but not organified. So patients with peroxidase deficiency will have an enlarged gland, elevated TSH, high uptake of iodine 1, 2, 3, deafness or hearing loss if found. It's called Pendred's syndrome. Here is another interesting congenital anomaly in the thyroid gland development, which is ectopic thyroid tissue. What's an ectopic thyroid tissue? As you remember from discussion of the embryonic development of the thyroid gland, it develops on the tongue at the level of the foramen cecum, and it's guided by the thyroglossal tract to its normal anatomical site. So if the development is arrested, it leads to a swelling in the dorsal aspect of the tongue. That's ectopic lingual thyroid. You find a swelling in the midline at the junction of the anterior two-thirds with the posterior third. Before deciding to remove, you have to do a thyroid scan, whether there is other thyroid tissue in the normal anatomical site, or this is the only present thyroid tissue that's found in an ectopic site. This is a clinical picture of lingual thyroid, and on the radioactive tracer is found below the chin, that's at the level of the foramen cecum of the tongue. Notice that the significance may be the only thyroid tissue in the body. So you have to do a radioactive scan. Again, this is the appearance of a lingual ectopic thyroid gland. Another swelling in the thyroid region that's of interest in the clinical course is the thyroglossal cyst. Again, remember your thyroglossal tract. If part of this thyroglossal tract remains patent and undergoes clinical cyst formation, it leads to the thyroglossal cyst. So it is a cystic swelling in the midline, moves up and down with deglutition. The second point that differentiates it from a midline cyst of the thyroid isthmus: ask your patient to open the mouth, protrude the tongue, withdraw the tongue, again protrude and withdraw. You find that the cystic swelling is going up and down with movement of the tongue. As the direction of movement is transmitted from the cyst via the thyroglossal duct to the central part of the hyoid bone, that may pass either within it, in front, or behind it, then the track continues upward till it reaches the floor of the mouth. So these are the two clinical tests for a thyroglossal duct cyst. Number one, moves up and down with deglutition. Number two, moves up and down with the patient opening the mouth, protruding and withdrawing the tongue. These are the history-taking items we have discussed before, starting from the personal history, the patient complaint, the past history and the family history. And in female, I think it's also important to interrogate about the menstrual history, because some cases of thyrotoxicosis will lead to menstrual irregularities either in the form of polymenorrhea or menorrhagia. After history taking in a thyroid swelling, you are going to do or to pick some points in your general examinations that help you to diagnose the swelling. So we say that the patient is of average build, attitude, facial expression. They look for the patient appearance on the left side to you, not of the diagram, left side of you. You find the skin is rough in a case of hypothyroidism, or you may find clinical evidence of eye affection, especially in primary thyrotoxicosis or Graves' disease, where this patient shows a clinical evidence of severe degree of exophthalmos. So we can discuss that the eye manifestations of thyrotoxicosis are collectively called ophthalmopathy, that are divided into non-infiltrating ophthalmopathy or infiltrating. The non-infiltrating ophthalmopathy is caused by sympathetic overstimulation of the Mueller's muscle, being a part of the levator palpebrae superioris, and it gives staring look, lid lag, and lid retraction. What do you mean by lid lag? It means that the upper eyelid lags behind the globe on repetition of upward and downward movement with fixation of the head. The second is infiltrating ophthalmopathy, that's caused by deposition of mucopolysaccharides behind the globe, and this include exophthalmos, ophthalmoplegia, affecting mainly the superior rectus and inferior oblique. So it will affect the upward and the lateral movement of the globe. The question is, what is the eye movement which is mostly affected in ophthalmoplegia caused by thyrotoxicosis? These are the upward and lateral movement of the globe, because the ophthalmopathy mainly affects the superior rectus and inferior oblique. You may find conjunctival inflammation and congestion that takes the name of chemosis. So again, the infiltrating ophthalmopathy includes exophthalmos, ophthalmoplegia, and chemosis. We have illustrated lid lag and what's meant by lid lag, while the lid retraction, you know that normally the lower eyelid comes tangential to the lower limbus of the cornea, while the upper eyelid is covering about 1 over 6 of the superior limbus of the cornea. So if you find that the upper eyelid is coming tangential to the superior limbus, while there is an increased area of the sclera exposed at the level of the lower limbus, this is a case of exophthalmos. But if you find that the area of the sclera is found between the superior limbus and the upper eyelid. This is lid retraction. And then, what to say in a case which is having a clear area of the sclera between the upper eyelid and superior limbus, between the lower eyelid and the lower limbus of the cornea. So this is, as illustrated in the figure in front of you, is a severe case of exophthalmos, a severe case of exophthalmos. Record your vital signs, pulse, blood pressure, temperature, respiratory rate. The pulse is evidently increased in thyrotoxicosis, blood pressure as a routine work, and as well as evidence of hypertension in medullary thyroid carcinoma when associated with pheochromocytoma in the multiple endocrine neoplasia syndrome. Here is how to count the pulse of the patient. In a case of Graves' disease, there is more evidence in the eye, but in secondary thyrotoxicosis, there are more cardiac manifestations. You interpret the count of the pulse, presence of irregularities, and the presence of hyperdynamic circulation. Examine the body from up down to search for number one, the eye manifestations. As we have discussed before, again, this is a case of severe thyrotoxicosis, chemosis, conjunctival injection, extraocular muscle impairment, as we have said before. Again, a case of severe exophthalmos due to thyrotoxicosis, conjunctival injection, lid retraction. Never mind about the old nomenclature like Darlimpel and von Graefe and others. We collectively call the eye changes in thyrotoxicosis as either infiltrative or non-infiltrative, as we have discussed before. Chemosis and conjunctival injection. Severe degree of chemosis and conjunctival injection, even keratoconjunctivitis. I like this diagram. The eye above is the normal position where the upper eyelid covers 1/6 of the superior limbus. A lid retraction, there is only sclera between the superior limbus and the upper eyelid, while the lower eyelid is coming in tangent to the lower limbus of the sclera. This is how to perform the lid lag. In the normal situation, the upper eyelid follows the globe on upward and down movement, while in lid lag, when you repeat the movement, the upper eyelid will lag behind the globe on looking downward repeatedly with fixation of the head. This is how to perform a lid lag. Put your index finger in a horizontal plane, fix the head, ask the patient to follow your finger up and down at a time. When there is repetition of movement, the upper eyelid will lag behind the globe. The globe descends downward, while the upper eyelid will lag above. Again, lid lag, lid lag. Xanthelasma may be an evidence of hypercholesterolemia, but may be also associated with cases of thyrotoxicosis. You go to the upper limb, you may find thyroid acropathy, that's clubbing of fingers in cases of thyrotoxicosis. If I ask you what's clubbing, clubbing means that there is an obliteration between in the angle between the nail and the nail fold. As you know, mathematically, every angle is having two sides, so the two sides of this angle is the nail itself and the nail fold. First degree of clubbing is that there is obliteration of that angle. It's called thyroid acropathy, and sometimes the nails are weak and can be easily moved. What's called oncolysis, also found in cases of thyrotoxicosis. Ask your patient to extend the arms in front like this. You find fine tremors in the fingers. Go to the lower limb, you may find pretibial myxedema that is having a raised surface, a leathery consistency, nodularity, sharply demarcated margin, prominent hair follicles. Pretibial area is the site, and it is tender on palpation. Again, myxedema, pretibial myxedema, but also occurring on the back aspect of the leg. Then you go to your local examination according to the clinician preference. It may be done from the back aspect or from the anterior aspect. Never mind, in both positions, you can detect your data on the clinical examination. Palpate the enlarged thyroid gland as being a swelling in your surgical interpretation. There is a swelling in the thyroid or in the frontal aspect of the neck. We take this figure as an example. This butterfly, this all by inspection. The first step is by inspection. Ask your patient to swallow. You find that it's going up and down with deglutition, and when he is having swallowing, look for the lower boundary of the thyroid gland. If you see the lower boundary on deglutition, so there is no retrosternal extension. If you fail to inspect the lower boundary, so this is a case with retrosternal extension. Note the presence of other separate swellings that may be lymph node metastasis in a case of thyroid carcinoma. Look for dilated veins in the skin overlying the thyroid swelling. Look for the presence of scar of previous operation, sinuses, and other items that may be fulfilled in your inspection. Notice the groove between the sternomastoid and your swelling. Is it empty or full? That's the groove between the sternomastoid and the thyroid gland. These are the items detected by inspection. Then we go to the palpation. This is done from behind, as you see. Comment on the swelling regarding the site, size, number. Is it diffuse swelling in the thyroid gland or a localized nodule in the thyroid gland? Movement with deglutition. Can you assess the lower boundary or not? Is it hard, soft, or firm in consistency? Palpate for the draining lymph nodes, and so you have to do a superficial palpation for hotness or evidence of inflammation, the presence of palpable thrill that may be found in Graves' disease, and then go to the deep palpation to interpret the criteria of the thyroid swelling you are having. Again, from the back aspect, we palpate the two thyroid loops. I can do it also from the front aspect to palpate the two loops. From the frontal aspect, two additional clinical signs can be performed. One of them is to compress the two lobes of the thyroid gland against the trachea. If the patient experiences dyspnea, it's a positive Kocher test due to compression of the two lobes against the trachea and the narrowing of the air passage. The second is to palpate the carotid pulsations. That's Beres sign. So Kocher sign to push against the trachea. Beres sign to feel the carotid pulsation. I can find that there is difference in the pulse volume that may be caused by compression by a huge thyroid swelling or very rarely actual infiltration in cases of carcinoma of the thyroid gland. So remember two additional clinical tests in palpation of the thyroid that are Kocher test, number one, number two, Beres test. Again, the interpretation of the carotid pulse, you can never say there is a difference in the count, but there may be difference in the pulse volume either due to a mass compression effect or due to an actual infiltration of the carotid. Again, here we are feeling the thyroid itself, interpret its size, consistency, margin, lower boundary, the presence of palpable pulsation. Then I go to the furrow in between the sternomastoid and the enlarged gland by asking the patient to push by his chin against the examiner's hand. And by palpation, I can detect tracheal deviation. A tracheal compression is a Kocher's test, but tracheal deviation may be caused by enlargement of one loop, so it will push the trachea to the other side. Feeling the carotid pulse is called Beres sign. Back again to the general examination, I have searched for signs of thyrotoxicosis, signs of deficient function or myxedema, retrosternal extension, malignancy, whatever regional effect of malignancy, or systemic effect that's evidence of metastasis by searching in bones, lungs, brain, and lastly, the liver. Is very rare to have metastasis in the liver. So, in speaking about metastasis in the different organs, consider the first site of location of metastasis. Here in the thyroid, mainly it goes to the lymph nodes, regional lymph nodes, and secondary to the bones. Don't examine a thyroid case with a covered head because you have to palpate the skull. So many cases we have detected bone metastasis in the skull, especially in follicular thyroid carcinoma. I think from now onward, the slides are going to discuss the different types of thyroid swelling, starting with Graves' disease. I think our domain today is the clinical interpretation, so we have restricted our talk to the history taking, general examination, and local examination. At the end of your local examination, you can say this is a case of thyroid swelling, most probably say multinodular goiter, most probably thyrotoxicosis, most probably malignant swelling of the thyroid gland for investigation. So our clinical discussion stops by the word that it's most probably so, and it needs investigations to settle the definite diagnosis of the case. And thank you.